Okay, so just to kind of pick this up because we have quite a few topics to talk about here, but a little bit of a like forecast, if you will. So next Monday, you guys will have your renal exam 5, and it's just renal phys, renal patho. So this will be the other percent or 50% of exam 5. Okay, it is less material, it's half the material. The exam, you guys are used to about 30 multiple choice questions. This one's going to be 20. So it's a shorter exam, still with one essay. Okay.
Same number of points though, so they're just pointed higher.
Yeah, same number of points though. Yep.
That's it.
That's it. Because I kind of made a mistake. I think I made this essay too hard to grade. It took me a lot longer. But just one essay on exam 5, and then that kind of brings us. After this, then we get to endocrine. Endocrine's the last big topic before the final. Emphasis on big hormones, lots of them going around, lots of them interacting. So just heads up about that. Tomorrow morning, just make sure you got coffee. Recommendation. Okay, but this one we're going to wrap up here. Yep.
So do we have a quiz on endocrine, or do we just go straight to the final?
You're going to have a quiz on endocrine.
Sorry, an exam on endocrine.
We do not have an exam on endocrine. Endocrine makes up 50% of the final.
Oh, set.
Okay. It is good and bad, and trust me, even though like endocrine for me, I still hate it, but I got you. I'm gonna leave that ominous here because we still need to get through this 50%. Okay. So urinary phys, 3 functions: filtration, reabsorption, secretion. When it comes to patho, there are 4 categories. I'm going to lay out the 4 categories. My recommendation when you guys are studying, fit these pathologies into these categories and make it a little bit more specific. The first category that we're going to be talking about is obstructions. Okay, so that's the first category of pathologies. Second category is going to be infections. Okay, the third category has a long name to it, sorry. Glomerulonephritis. It's kind of its own little thing there, so we'll leave it there. And the last category is failure. So again, when it comes to organizing all of this stuff here, these are the 3 categories, because take, for example, you don't need to fill this in yet if you don't want to. We'll be talking about upper obstructions. We'll talk about lower obstructions. We'll talk about bladder infections versus kidney infections. This acute versus chronic failure, acute versus chronic. We're going to get there, but I'm just saying, like, if you have this chart as you guys are studying, this kind of is your overview. Okay. All right. So starting up, urinary tract obstruction. Don't overthink this one. It's just some sort of obstruction that is an obstruction that is causing some sort of interference with the flow of urine. Duh. Okay. 2 different types of obstructions we'll be kind of talking about. Anatomic, this is kind of, let me just give you the example here, like an enlarged prostate. So an anatomic obstruction is there's a bodily structure that's too big. Something has gotten too big. Functional is usually the byproduct of like a process, i.e. kidney stones. Okay. So those are really the kind of 2 obstructions we'll be talking about. 2 types. All right, on this slide here, this is every single possible obstruction you can have. Now, you don't need to memorize these. We only need to know a few, but I'm just saying, hey, look, your kidneys can have an obstruction, your ureters can have some obstructions, your bladder, your urethra, so on and so forth. Okay, every possible obstruction, we're only going to be looking at a few. Okay, so notice we are in the upper tract. Remember how I told you categories of obstructions, there's a subcategory of upper, these 2 would go in there. That's what I'm saying, like that might help you organize the info. Okay, first up, hydroureter. Hydro refers to water, ureter, ureter. Okay, so water in the ureter, i.e. too much water in the ureter. Now, be careful. Your ureter looks very similar to urethra in terms of spelling. What's the big difference between your ureter and your urethra?
Your water.
Yep, ureter connects kidney to bladder, i.e. ureter is upper tract, urethra, lower tract. Okay, so we're still talking about the upper here. So what's the issue here? Your ureter, take for example this right here, is just a tube. What's going to happen if you have too much water in your tube? Distension, and that's exactly what this is. So hydroureter is distension of the ureter. And I'll show you guys pictures of this. Underneath that, hydronephrosis. Basically, a condition of too much water in the nephron. The nephron was the functional unit of which organ? Kidney. So hydronephrosis, condition of too much water in the kidney. Same thing, your kidney. If you have too much water in there, it's going to cause distension. Okay. So, which one's more pathological? We've got hydroureter, hydronephrosis. Okay, we're evenly split. Nephrosis. All right. So kind of think of it this way. How many functions do you lose? Hydroureter. Your ureter has how many functions? One. Just urine from the kidney to the bladder. How many functions does the kidney have? What were the three functions? Filtration, reabsorption, and secretion. So therefore, hydronephrosis is more pathological because we lose more functions. Okay. And I'll show you guys a picture here to kind of help make things make some sense. All right, so in this picture here, that is hydroureter. That right there is hydronephrosis. Okay, so clearly you're seeing distension, yeah? Now, what could cause something like this? I'm going to say like it could be a kidney stone. So imagine if I had a kidney stone blocking my bladder right here. My kidney stone completely blocking the entrance to my bladder. Water is going to build up behind the kidney stone, causing it to distend. So that's hydroureter. If the water starts backing up, distends my ureter, what structure would be next? So what I'm trying to get at is hydroureter can lead to hydronephrosis. Well, sorry. So hydroureter can lead to hydronephrosis. You guys kind of see how that water just keeps backing up. But what if I just have an obstruction at the kidney? Would that cause hydroureter? No, it would only cause hydronephrosis. Does that kind of make sense? So it just depends on where the kidney stone is. Very much like your GI tract. There's a process from mouth to butthole. There's a process from kidney all the way out. Okay. Another kind of thing to point here. So this is the cross section of somebody's kidney with hydronephrosis. We can see how the major calyx has expanded. There's pressure building up behind it. Notice what's happening to the renal tissue. It's kind of inflamed. It's being compressed. It's being squished. So water's building up behind here, causing this to expand. We're squishing the tissues. So compression of renal tissue, right, caused by that pressure, is going to do what to blood flow? Ischemia. So what's another reason why hydronephrosis is more pathological? Risk of renal necrosis. Absolutely. Okay. As I was talking about your girder, that's exactly it. It's just a tube. There's not a lot of muscle there. There's not a lot of tissue there. It's just a tube. Okay. So, question. Will your kidney explode? Will it explode? Will it rupture if it looks like that? It could.
It's not really hollow.
Not really hollow. So let's just say your kidney looks like that. Are we screwed? Are we dead? Why not? How many kidneys you got?
2.
So if one kidney looks like that, we're just going to divert blood to the other kidney. So will my kidney explode? No, unless I get hit by a car or something. So it won't rupture on its own. That brings up this idea of compensatory hypertrophy. Now, this is actually a very important concept. That's why I'm going to put a pink star next to it. Pink means compensatory hypertrophy. Compensatory hypertrophy. So you guys remember hypertrophy. What does that mean? Increased size, and we're compensating. So increased size to compensate for, I'm going to say bad. You can say defective for a bad / defective kidney. Okay. So if a patient has hydronephrosis typically only happens on one side, typically. So if the patient has hydronephrosis, would that cause compensatory hypertrophy?
Sure.
Absolutely. If one kidney looks like that, your other kidney is going to get bigger. Why? If you have a bigger kidney, you can filter more blood. You can reabsorb more things into the blood. You can secrete more things. How many kidneys do you need to live?
1.
Just one. Okay. So if one kidney looks like that, the other one's going to get bigger. What would be another example of why someone's healthy kidney would get bigger? Sorry, what was
Infection.
maybe infection? We'll kind of get to that long-term infection of the kidney. If we took one out, absolutely. So I'm going to just do the simple. I'm going to go with the simplest one. Example: kidney donation. If I donate my kidney, the kidney that's left, it has to get bigger, has to compensate. Fun fact, if you are donating a kidney, the person receiving the kidney, we generally don't take out the bad kidney. That means there's people walking around with 3, 4, 5 kidneys inside of them. Just depends on what it is. If it's cancers, obviously we're going to take it out, but most of the time we leave the bad one in there.
It doesn't just completely over rot.
I'm not a surgeon, like I'm not making those calls, but for whatever reason.
Somebody has like a horseshoe. Does it just function as one?
Horseshoe kidney.
No, it doesn't like.
I imagine, yeah, you might just have like a super mega kidney. So effectively, like, or I may say, anatomically you have one, but physiologically you still have the same kind of functions as 2. Yeah, that would be my guess.
My brother has that. He was born.
Yeah, I know.
Yeah, kidney size too. It does the function of both.
Yeah, it functions like 2. Anatomically, there's just one. That's my guess. But it should be fine, especially it'll get bigger to adjust as it goes. Post-obstructive diuresis. Post means after. obstruction. Diuresis is urination or to urinate. So I want you to imagine you have been unable to pee for the last 3 days due to some sort of obstruction. When you finally get that obstruction cleared, how much urine would you anticipate? Damn. Okay. So
We appreciate on the exam of the question about Dick with their answers, 'cause that was. Oh my God, I was cracking.
there was a question about me getting dick, and one of the options was like, "How did this happen?" It's like Tinder was an option.
Oh, did I see?
Okay,
Yeah.
I'm sorry, I was like, how does that relate to me?
Oh, it was funny.
All right. So still talking about upper tract obstructions, mainly renal calculi or kidney stones. The way I think about this, renal calcium stones. Okay. They're masses of stuff. You don't need to know what exactly. What I need you to know is what they are typically. And they are typically
That's on the upper obstruction.
kind of. If the kidney stone gets stuck in the kidney, would that be an upper or lower? Upper. If it gets stuck in the ureter, upper or lower? If it gets stuck in the bladder, lower. If it gets stuck in the urethra. So technically a kidney stone can be anywhere. So it can be in the upper or the lower, just depends on where it gets stuck. Okay. You do not need to know the difference between calcium oxalate or calcium phosphate, just calcium, good enough for me. Okay. You do not need to worry about struvite stones or uric acid stones. If you're curious, struvite stones, these are from ammonia crystals. Uric acid is from urea. You kind of see that with gout. So people with gout, these uric acid crystals can also get uric acid renal stones. But again, mostly worried about calcium. Okay. All right, so how does a person get kidney stones? Supersaturation, i.e. you have too much calcium in the urine. Anybody as a kid ever grow like sugar rock candy or sugar crystals? The idea is you have a lot of sugar, a little bit of water. Then they start forming crystals. That's what kind of happens. You have a lot of calcium in your urine, starts making these stones. Okay. Risk factors. Risk factors include urine concentration. So i.e., let's think about this. Super concentrated urine or super dilute urine? Which one's going to increase your risk for kidney stones? Super concentrated urine. Okay, so high urine concentration. What causes your urine to be super concentrated? Dehydration, coffee, diuretics, Mountain Dew. Okay. Temperature really doesn't play too much of a factor, but it's if someone is perpetually cold. If someone is perpetually cold, just talking about like hypothyroidism. Okay. pH less than 5.5, i.e. very acidic urine. Very acidic urine. That kind of adds to the high levels of or high concentration. Okay. Last one, which is also the most important one, calcium carbonate. Calcium carbonate, i.e. the most important risk factor, dietary. Like I'm trying to emphasize this. The number one important risk factor for kidney stones is dietary. Okay. So when's the last time you ate calcium carbonate? It is Tums. Calcium carbonate is chalk. Tums is just chalk with salt or sugars. Okay. So antacids. Oh yeah. The fruit flavored ones, absolutely. So let's kind of go down this rabbit hole a little bit. Okay, let's go down this rabbit hole a little bit. Tums, antacids. Thanksgiving just happened, yeah? When you're feeling a little bit of heartburn, what do you do? usually pop some Tums, maybe pops, drink some Pepto. But think about this really applies kind of to the older generation. They'll pop Tums, what, 3, 5 of them in one meal? That is a lot of calcium carbonate. Carbonate goes to neutralize the stomach acid. Now you have a bunch of calcium in your GI, a lot of calcium in your blood. In order to put that calcium into your bones, you need what? Vitamin D. Does Tums have vitamin D? So this stays in your blood and it goes into your urine. Okay, so popping antacids, they're fine, it's okay. The problem was back in the mid 80s, early 90s, the dietary recommendation for a kid, hey, you need calcium. Here, eat some antacids because they're sugary, they're sweet, they're cheap. Is that going to help their bones? Is that going to help grandma's osteoporosis? You need vitamin D.
Would pregnant women be at risk?
Oh, yes. Oh, yes, because,
Because I looked a lot when I was.
yeah, and the calcium, especially during pregnancy, if you don't have enough calcium in your diet, the developing, fetus will absorb calcium from the mom's bones. So in poorly nourished pregnant women, you can actually see osteoporosis develop, and then they have to resolve it post-pregnancy. So easy on the Tums. Okay. Now, what happens is these stones, this calcium, starts to collect in these tiny, sharp little corners. Anybody remember what these minor? Yeah, it's the minor calyces. Okay, your minor calyces are these sharp little corners. This is why kidney stones have a very jagged appearance. So there's a minor calyces shape. It's a very unique shape. It's called a staghorn appearance. Staghorn appearance. Okay. Now, what's kind of interesting is as these stones are developing in these sharp, jagged little corners, they take on that sharp, jagged appearance, right? Development is asymptomatic. Development is asymptomatic, i.e., would you know if you're developing kidney stones? How does a person know that they have kidney stones? When they start moving. Yeah, when they start moving, that's when you know that you have kidney stones. Okay. So here they start developing. Sometimes they can become even bigger. Okay. Again, if my kidney stone goes on to block, take for example, right here, what would that lead to? Hydronephrosis, right? Because water's going to start pushing up behind here, causing my kidney to compress, to stent. Okay. Upper or lower tract obstruction. Upper in this case. Okay. So just a little FYI, because we're going to come back to this structure. This final section right here, that's your renal pelvis. So if a kidney stone causes an obstruction in the renal pelvis, that would be an upper tract obstruction. Okay. Like this stone right here is going to cause havoc. Okay. All right. So some stones can be particularly pretty nasty. Minor calyces are clogged up and even into the major calyx. Okay. The kind of extra shit cherry on top here, your kidney stones don't ever get smaller. They either stay the same size or get bigger. Okay. So different types of stones. If you notice the kidney stone down here, you have very sharp corners. It's kind of hard to see. It's a little washed out here. But these corners, are they smooth? Oh, these are like serrations. These are sharp, pointy serrations going through the tissue. Now, as you're going through the tissue, it's cutting, ripping, tearing the tissue. Okay. These are different types of stones. So this one's actually a calcium stone. This is, I believe, an ammonia stone, a little bit smoother, but still blockage. And that's a uric acid stone, if you're curious.
Are those names?
It's a Google image there, so I have no idea.
Okay.
I would say those three descriptions will apply to any stone,
Yeah.
to be completely honest.
I was like, your doctor popped out and was like, oh, this is an agony.
So the number one thing that kidney stones are famous for, what is it? Pain. This pain is so prominent, so unique, it has its own name. Renal colic is the number one clinical manifestation of kidney stones. Renal colic. Okay. So this is a specific type of pain. It's going to radiate. It's radiating flank pain. That pain is going to radiate from back to groin. Radiating flank pain, which means it's going to radiate from the back to the groin, and it never subsides. Usually, it only gets worse. Anyone ever have a kidney stone out of curiosity? Would you guys agree?
Yeah.
Yeah. So a little bit of a story. My father, he was a Marine in Vietnam War. Old school, hardcore badass, right? Straight up, got shot in the stomach, got gut shot in the stomach, hiked 2 kilometers with his buddy on his back to firebase. This guy's tough as nails. Does not ask for help, doesn't really feel emotions. Sorry, I'm just like, I got daddy issues. 8 years old. I'm sleeping in my room. Okay. It's like maybe 2:30 in the morning. My dad comes over and wakes me up. And he can only amount a whisper. And he says in my ear, son, call an ambulance right now. I am downstairs waiting. Proceeds to walk out of my room and then stand, not sit, but stand on the front porch waiting. That was the only time he's ever asked for help in his entire life. Okay, why? Why is this pain so severe? Why does it never subside? Why does it only get worse? Okay, so it gets narrower and narrower, constantly digging. Now these sharp stones, they're constantly ripping and tearing. That pressure is increasing. Do you agree? Okay, so I have like all of these tears. Now what's behind the stone? Urine. And what's in urine? Acid, salt, other stuff, pressure. So as the stone is moving, constantly ripping and tearing new tears, you're rubbing salt, acid, and high pressure into that wound. Sucks?
Yeah. A lot.
So don't get kidney stones. Okay. Another symptom you might see is you might see hematuria. You might see hematuria, depending on how big the stones are, etc. I.e., what is hematuria? Bloody urine. Exactly. Okay, so how do we treat kidney stones? Couple of things, high fluid intake. Now, can I ever dissolve a kidney stone? So why am I saying more fluid? Pressure, increased movement, you're trying to pee it out. I.e., the high fluid intake is to try to get it out of the system as fast as possible. Okay.
We also add high doses.
It's kind of interesting. We usually don't provide a lot of pain treatment there
Ow.
because we need to know when it's all out. Decreasing intake of stone forming substances. What do people need to cut back on? I was going to say calcium carbonate because of branding. Okay, now in terms of removal, we don't generally like to do procedures to remove stones unless in extreme situations. Why? This is a little just FYI here. We generally prefer patients to pass their kidney stones by themselves because if we do a procedure, there's a high risk, high correlation of stones forming it again. I.e., if we go out there and dig it out, they're at risk for forming it again. Don't know why. Okay. So there are a couple of different ways we can do it. This is one of the cool ways. Here's your kidney stones. That's kind of big. We'll use ultrasound. Ultrasound, basically just like any other ultrasound via one. It's a little bit higher frequency, and it shakes these stones, and only these stones, because of the molecular weight, causes these stones to start breaking up into smaller fragments. So this is a couple of other ways we can also remove stones if need be. So we're going to insert a catheter past this big stone. Now this is almost like a dental drill. It shakes the stone into a bunch of little pieces, and then we squeegee it out. Yep, usually.
Oh my.
Now, why? Actually, let me back up here. What's the problem with this procedure?
End up pushing it further back up.
We could push it further back up. Think about the stone right here. How tight of an area is that?
Great.
And now I'm shoving a catheter through it. So it could stretch the tissue even further. It could rupture the tissue. Okay. They might numb you a little bit. Depends on how nice you are. This is nice though, because hey, this will clear up your hydroureter. This can clear up your hydronephrosis. This one's a little bit more drastic where it's stuck. So we have these robotic arms. This is actually really cool. This is the same technology they use for tattoo removal. We use a laser. It vibrates at a certain frequency, only affecting certain elements.
I've used one of those. When we go in and we take out gallstones, we have one of those to go into the common bile duct and break them up. It is the coolest thing I've ever seen.
It's actually quite fascinating. But anybody see the problem with this procedure?
Pulling it back through. Then we can. It's exploding.
It just hurts the stones, but that's one.
Two.
Two.
Yes, you're
Three.
going back and forth, back and forth.
How much trauma are you putting onto that tissue, shoving that back and forth, back and forth?
Almost more than I think sense itself, because you're just doing it over and over.
Exactly. So that's again one of why I say generally we don't want to use surgical intervention. We want to try to let the patients pass their stones. These are really only reserved for like pretty bad situations.
So when they break it up into smaller pieces, they wouldn't just leave the smaller pieces there?
Depends. They can break it up into smaller pieces, but they probably have to keep going back to the bigger ones or break up the bigger ones into smaller ones.
Oh.
Okay. All right. So upper, now we're moving to lower here. Lower is your bladder and your urethra, starting with a neurogenic bladder or dysnergia. These are the same thing. Actually, let me do it on this side. These are the same thing. Two different names for the same thing, i.e. dysnergia, neurogenic bladder. This is autonomic nervous system damage, leading to a loss of parasync control. Okay. So a neurogenic bladder, i.e. dysnergia, I have an autonomic nervous system damage, i.e. I can't involuntarily control my smooth muscle anymore. Okay, remember your parasympathetic nervous system controls your bladder. So this can manifest in two ways. You can have detrusor hyperreflexia. Anybody remember what the detrusor was? That's the muscle of the bladder. Detrusor hyperreflexia. The muscle is hyperreflexive. What do you think that bladder is constantly doing? Constantly contracting, spasming. Constant bladder contraction. Okay, again, I have lost control, so it's either constantly contracting or we can see detrusor areflexia without reflexes. What's my bladder doing there?
Just relaxing.
Bladder can't contract. Okay, so patient has detrusor hyperreflexia post CVA. What would be the expected urine output, high or low? So patient has detrusor hyperreflexia after a stroke, CVA. What would be the urine output?
I feel like it could be low, because like, tracks like, well, urine.
Yeah, it's kind of a tricky question there. Two things. You have frequency and you have, actually, let me say, frequency and you have volume. So let's start with urinary frequency. Would you expect to be high or low?
High.
They're constantly urinating, constantly. But how much are they urinating? They're piddling. Okay, so a patient has detrusor hyperreflexia secondary to their stroke. What would the nurse expect in terms of urine output? Low volume. Absolutely. Okay, what would the nurse expect in terms of frequency? Higher frequency. Detrusor areflexia, what would you expect from the frequency? They're not peeing very often. Generally, they can't pee. We need to stick a catheter up there. Okay. So if their bladder can't contract, that's a lower tract obstruction. But when you finally do get them to pee, how much they urinate? Okay. Okay. So do you guys see how that's a lower tract obstruction? It's the bladder itself. So basically a lower tract obstruction is just some sort of obstruction of the bladder or tumors. Stop. Little bit of review here because I noticed this was on the exam there. I think I saw a couple people miss it. Renal adenoma, OMA. What do you instantly know about this tumor?
It's not.
It is benign. It's not malignant. Carcinoma. What do you instantly know about this tumor? It's malignant. It's cancerous. Okay. So tumors can obviously cause an obstruction. Now, if we have a renal tumor, a renal adenoma, is that upper or lower tract obstruction? Upper. Renal, kidney, upper, right? Renal cell carcinoma is malignant. It is highly aggressive. Highly aggressive. Why?
Because I feel like those cells are constantly.
It's cancerous. There's high cell turnover rate. What else makes the cancer grow faster? High perfusion. Highly aggressive due to high perfusion. Do your kidneys get a lot of blood? Give or take 20 to 25% of overall blood is in your kidneys at any given point. So a quarter to a fifth of all of your blood is in your kidneys right now, constantly moving. Another weird oncology fact here, renal cell carcinoma is highly resistant to medications. So chemotherapy doesn't seem to have a great effect on renal cell carcinoma because blood's going through your kidneys. Not only do you have a lot of it going through your kidneys, but it's going through very quickly. The blood does not stay at the kidneys long enough. Okay. Now, bladder tumors are gross, like icky, but gross in the medical field means large. Like you can actually physically see it. You might be able to you might be able to palpate it. Painless hematuria, i.e., they might just pee blood randomly. Very different from painful hematuria seen with kidney stones. Yeah. Smokers. This is the #1 risk factor for bladder cancer.
There it is.
There it
Yeah,
is.
thanks for that question 2 exams ago.
I dropped it. But guess what's gonna probably be on the exam for this one?
Yeah.
Sorry, guys. But yeah, that's what I was finally trying to get to. Smoking cigarettes, #1 risk factor for bladder cancer, not renal cancer, but bladder cancer. Okay. I like it when you guys call me out on my bullshit. It's great. Like, I actually genuinely like it. All right, so this right here. This is benign. Why? It's a renal adenoma.
It's fat too.
How else do you guys know that it's benign? It hasn't broken the basement membrane. It is still encapsulated. Okay, very good, very good. Now, somebody's kidney looks like that. What is treatment? Ideally, treatment for any benign tumor is surgery, right? We're gonna go through and, I don't know. That's kind of tight. If I make one mistake, remember I told you your kidneys have 20 to 25% of your blood? I nicked the wrong thing, I'm gonna have my patient bleeding out. Maybe I won't take out the tumor. I'm gonna take out the whole kidney. Why will they be okay?
They have another one.
You have another one, and what will happen to the other one? Compensatory hypertrophy. So I'm gonna say treatment, remove the kidney, because we have the healthy kidney. Healthy kidney will undergo compensatory hypertrophy. So it's a lot easier just to take out the whole kidney, is what I'm trying to get at here. It's easier to take out that whole thing rather than try to operate around it. So this is renal cell carcinoma. I'm gonna be honest with you guys, I had no idea that this was a kidney when I first saw this picture. But this is what I mean by that malignant cancer is highly aggressive. That's somebody's kidney cut in half. The only way I could tell that this was a kidney, you have one renal medulla down here. That's it. Okay. Depending on how malignant it is, if it's in the other kidney, can we expect compensatory hypertrophy? All right. You guys cool if we keep rolling through infections? All right, yeah. We'll take a break.
Like,
I need you guys to like listen to Mother Nature here.
we don't want you here.
So we'll go like 7 minutes. So 38. That would be 48. No. 42, 44, somewhere in there. Thank you. Do you guys know what sparked the whole Denver mask mandate all over again? Out of curiosity. That's what I'm wondering too.
Holidays, large amounts.
Oh yeah,
Yeah.
yeah. They were going to say that like this is now the 4th wave to be expected.
What was your question?
About what sparked the mask mandate? Like I'm all for it, but I know. I mean, I'm glad that they're finally
Yeah.
taking action.
Yeah, I don't know, but then they put in exceptions for a lot of businesses. There's a
Oh.
loophole in ours where businesses can choose between mask mandates or proof of vaccination, which continues the
debate.
idea that vaccination prevents catching it and transmission, but it is, I don't know, it's like can't seem to do more than one thing at a time, I guess.
Yeah. I think it is that new variant though.
A little bit, yeah.
Which one is it now?
They're calling it the Omicron.
Omicron.
Omicron. It's coming out of South Africa, and what's kind of weird about it is it's kind of like the very similar to what we saw with the Delta. Highly variant, so highly mutated, highly infectious, but the thing that people are like kind of, I guess, knee-jerking reaction about, it's changed its age group. Before COVID was deadly for like people mid-30s, 40s, older people, 20 and 30s.
It's getting lower now.
But it seems like, I mean, I don't know how they report it, but it seems like the cases have been mild thus far for people who are vaccinated, but it can be lethal for quote unquote young people. And that's what, I don't know. I'm not an economist, but I know with labor shortages and the great resignation of 2021, if you're losing 20 to 30-year-olds, the economies are gonna crash.
Yeah.
So that's my guess. I thought that's what was stimulating the mass mandate, or I don't know, Denver's just like,
I think it's a new variant, but that's what they're worried about.
yeah. And it is, you know, 6th season now. Ugh,
Hey, you like medals, yeah?
yeah, you metalhead?
Kind of. I like art stuff. I like grew up really into grunge music. She's a metalhead.
I noticed you were
Posters.
the rise poster in the background when we're on Zoom. I was like, oh, okay.
Yeah.
Like, what kind of metal?
Shitty metal.
My old roommate writes Jen.
What writes what?
Jen.
Jen?
It's like that really chubby kind of metal.
Jen?
Jen music. So it's like.
Heavy on the
It's
bass?
like expensive stuff.
Hmm,
Since like, it was in summer. So like,
yes,
those
okay. Yeah, I'm into that new metal, that post-hardcore screamo. Back in the day, I had the bangs and everything.
Oh, yeah. Oh, me too. My hair was parted, you know, all the way.
Yeah, I used to be like, big, much more into the whole I was a skater chick with like hair was I would. Have you ever heard of the band Special?
No.
They're like more in the like jam band scene, but
Sure.
they play pretty hard sets. And they're playing at the small venue in at Cervantes, playing at Cervantes this Thursday.
Oh, nice.
And I figured I would tell you because they are
They're on point.
fantastic. They're very good. And they're like a smaller band that I really want to blow up.
Oh, what is it? One more time?
Lay Special.
Lay special.
Yeah, LE Special. But it's all one word.
Okay.
They have, I mean, they do like a lot of, kind of, yeah, pretty much. They do like a lot of, they do a lot of like Primus covers, a lot of Rage Against the Machine.
Gotcha.
Other ones, but very good.
Yeah, I think like new age metal for me, it's weird that they're calling it classics now, but Bring Me the Horizon kind of, and then Kill Switch Engage. It's something about like middle-aged fat guys playing at a metal concert. I like had this revelation when I was 20 something and I was raging in the front and we were moshing. It's like I've never been so happy to have a middle-aged guy spit on me, like while singing. What a life I've lived.
I've never been happy to be knocked down in the circle pit and stuff.
But like they take care of you.
Oh, yeah, some big dude was behind you to pick me up.
Oh yeah.
Because like if you go down, you can get trampled, and people were paying attention, so.
Yeah, that's why I like the metal scene or like rock scene. It's just
Older cast, definitely not after.
like, you know,
That's why the jam scene, they're all a bunch of older,
chill.
really chill. I always go by myself too, and I never felt unsafe, never.
Right.
It was like some old dude with like piercings and a mohawk. A lot of those.
Is your card on your
No, it's
Everyone's gonna ask.
I know, that's actually kind of why I put it in.
But
No, I've had it pierced, but I always had a clear spacer in it. When we first started lecture, you know, at the beginning of the quarter, and I was like, hi guys, I'm your professor. But now 9 weeks in, I don't have any facades to hold up. Now I was kind of had it as just like, because it goes back to, I used to be a skater and a metalhead and all that. I don't know, y'all want to be nurses and I respect that, absolutely. And I want to make you be the best nurses you can, but you guys all have a past. You guys all come from somewhere. You guys are all people. Don't lose that in the process. right? What has shaped you to be here today? Don't lose sight of that. You know, like I think a lot of students forget why they do nursing school. Get wrapped up in, oh shit, you have an exam on Monday. Oh, and you have a health assessment exam, and hopefully you guys got all your online papers in and all that. The details, people get lost in the details and they kind of lose or forget that. So that's why I usually put it in at the end of the quarter, because, you know, I don't like, from an administrative standpoint, it wouldn't make sense to fire me yet. But like if I had it in the beginning, like, sure, okay, they can still replace me.
Ryan was fine line.
It's dangerous.
I've definitely done that. A couple jobs. Well, that's why I cover up the tattoos and then slowly start going into work. Well, it's like showing them. it's like,
Interview.
You gonna do anything? No? Okay, cool.
You always do an interview covering everything,
Uh-huh.
and then the first day, bam, they're like, oh, what the hell?
Surprise. But yeah, I don't know. It's always been like a, it's just a thing for me.
Don't work out there.
Kind of does. I mean, I don't tuck in my pants anymore. I don't tuck in my shirt anymore. All right, so let's talk about UTIs. So UTIs are actually pretty simple if you know the Latin. Okay, when it comes to the Latin here, cystitis. Anytime you see cystitis, you know it's itis, inflammation of the bladder. So you instantly know that these are bladder. The bladder is inflamed. So let me just say bladder inflammation. So anytime you see cystitis related to a bladder infection, bladder inflammation. Okay. Anytime you see pyelonephritis, again, itis, inflammation, but the pileo part. Pileo. It's in the nephrons, kidneys. What structure would be inflamed in the kidneys? This is what I'm saying is be careful. PY, people think renal pyramids. That is not true. Pyelonephritis specifically refers to renal pelvis. So be careful. I'm saying that's a common mistake. Renal pelvis inflammation.
So these go in the infection.
This is going in the infection category, and there's two subcategories in the infections. Take, for example, cystitis, upper or lower?
Upper, no, it's flat.
Bladder, lower. These are your lower UTIs. Pyelonephritis, therefore, would be an upper UTI. Okay. Now, the difference between acute cystitis and non-infectious cystitis, acute short term, it's some sort of infection. Non-infectious cystitis, this is inflammation from, I don't know, a kidney stone tearing through you. Okay, so there's an infection here, not so much an infection. We'll talk about pyelonephritis because that's the whole picture. Now, most common cause is E. coli. E. coli is a colonic bacteria. This lives in your colon. How the hell does it get into the urinary tract?
Welcome back.
When you drive the wrong way down a one-way street. Okay, and we'll talk a little bit more about that. But here we're seeing cystitis. We're seeing bladder inflammation. Does anybody remember what this area is called? Yeah, this is the trigony or trigon. Hurts me when people call it trigon. So the trigony is the area of the bladder that is most likely to become red and inflamed with a bladder infection. Okay. All right. So you got your birds, you got your bees. Let's talk about risk factors. Now, risk factors for developing a UTI. We talked about wiping the wrong direction, so I'm going to say poor hygiene. Now, normally you're like, why would someone ever wipe the wrong direction? You guys have painted the fence before. It applies to caretakers. When you guys are wiping somebody, just please keep in mind the direction of the paint. Okay? So what else increases your risk for a UTI? You mentioned. I'm gonna leave that there. To each their own.
Yeah.
But you were talking about when we needed to take a break. Why did we need to take a break?
Oh, yeah, well,
Holding your pee. Yes, the longer you hold your pee, the more at risk you are for developing a UTI. So nurses, when you're working a 12-hour shift wearing your compression socks, make sure you go to the bathroom, take care of yourselves. Okay. What else puts a person at risk? Dehydration. Certain medications, I'm not going to touch that with a 9-foot pole. Birds, bees, who's at risk?
Women are more at risk.
Women. Why are females more at risk for UTIs? Shorter urethra, yeah. Okay. Next one I want to emphasize here. Diabetes. Mainly uncontrolled, poorly controlled diabetes. Okay, diabetics, we'll talk about it more with endocrine, but diabetics, they pee sugar. There's glucose in the urine. So, I'm gonna use the male here. This is very Hansel and Gretel. If I am a diabetic, I'm peeing out glucose. There's a trail of breadcrumbs for the bacteria to crawl. So then it's going to get in here, causing what kind of infection? What kind of UTI? Acute cystitis, bladder infection. How do I get a kidney infection? Kidneys produce the urine. So what I'm getting at here is if somebody has a bladder infection, that puts them at risk for a kidney infection. Now, if somebody has pyelonephritis, somebody has a renal kidney infection, what do they probably also have? They're all UTIs.
Oh.
If somebody has a kidney infection, what else would probably be infected? The bladder. Okay, so what I'm getting at here, if you see pyelonephritis, chances are you will also see cystitis. Okay, pyelonephritis is worse, more advanced. Okay. So talking about acute cystitis, again, inflammation of the bladder, typically due to E. coli. Okay. Now, those are people with a bladder infection or a UTI, what happens to the frequency of urination? We see an increase in frequency. We can see dysuria, i.e. difficulty urinating. Okay. You might see suprapubic pain, i.e. flank pain. Okay. You might see cloudy urine. That's kind of like the tall tale sign. If you see cloudy urine, what would be in this person's urine to make it cloudy? Combine that answers. We have pus and white blood cells. What white blood cells? Which dead white blood cells? Cloudy urine actually comes from there's a lot of food stuff.
Sorry. Seen many a thick urine.
Yes. So kind of think about this. That is pus in the urine, making it cloudy. Because dead neutrophils, just like in a wound, indicates what? Infection. Okay. Now you may or may not see fever. I'm going to tell you, don't mark fever on this one. The reason why I say don't mark it is, again, you may or may not. A bladder infection hits people differently. Some people, terrible. Other people? Okay. You might also see hematuria. Why? Hey, if there's white blood cells, chances are there's probably red blood cells as well. Okay. Little green bits there, those are E. coli, I think. Actually, let me kind of back up here, sorry. Let's say someone has a really bad case of acute cystitis. We'll say that this infection goes on for about a week. Would you see compensatory hypertrophy?
They have.
Yay, nay? Would you see compensatory hypertrophy?
Yeah.
I'm hearing a no, I'm hearing a yes.
I don't know what happened if it's spread on the shoe. Yeah. I don't know if it's spread, yes.
I will. All right, so your bladder is inflamed. Let's just say it's obstructed. Where's water going to back up? Left, right,
Maybe both.
both. So water's going to back up both ureters into both kidneys. Would you expect to see compensatory hypertrophy?
No.
Because it will affect both kidneys. The other part of this, I mentioned that this person had a bladder infection for a week. Is a week enough for you to grow a new kidney? Too short term. Too short term. All right. Pyelonephritis. So with pyelonephritis, what is inflamed?
The renal pelvis.
Infection of the renal pelvis, usually by E. coli. Okay, this one, you're definitely going to see, so let me say symptom. You're definitely going to see fever. Most likely. Why? Think about your kidneys versus your bladder. Which one's deeper inside of your body? Kidneys. So if the infection's in your kidneys, that's going to affect your core. That's going to cause you to have a fever. Okay. Renal pelvis. Renal pelvis is this structure right here as we leave the kidney. Okay. So with acute pyelonephritis, would you anticipate compensatory hypertrophy? I think you guys are both right. So the answer is no. We would see no compensatory hypertrophy. No compensatory hypertrophy. Because it's acute, it's resolved too quickly. Okay. Now, regarding this here, if we have inflammation of the renal pelvis, inflammation of the renal pelvis, does that make it narrower or wider? Narrower. So that's going to cause narrowing. So if my renal pelvis narrows, do I move more or less urine? This is going to cause a decrease in GFR. Now, if I have a decrease in GFR, what happens to urine output? Decreased urine output. Okay. So this is kind of like the big difference here. With a bladder infection, you're seeing increased frequency of urination. Here, you're seeing less. Okay, so there's like a switch there, and that's why. Now, chronic pyelonephritis. Basically, chronic pyelonephritis is reoccurring episodes of acute pyelonephritis. So my renal pelvis becomes infected and inflamed over and over and over and over again. Each time I become inflamed, what do I start laying down? That's what makes it permanent, scar tissue. Okay, that's what makes it chronic. So I'm going to say irreversible. Okay. Now, would you expect compensatory hypertrophy with this? If one kidney gets filled with scar tissue, yeah, absolutely. This would be, yes, compensatory hypertrophy. Okay. Now, causing this inflammation over and over again, it could be infection after infection after infection, or it can be caused by some sort of obstructive pathological condition. What would be obstructive and pathological going through there causing scar tissue? Kidney stones, renal calculi. Okay. So what I'm getting at is chronic pyelonephritis. We have scar tissue. That scar tissue can be from infection after infection or really gnarly kidney stones. Okay. So again, just saying this right here as we exit, that's your renal pelvis. All right, question for you. Kidney A versus kidney B. Which one is the healthy kidney? Correct answer is the healthy kidney is A. The healthy kidney is A. How on earth is that healthy? Compensatory hypertrophy. Kidney A has to get bigger. It has to get bigger to make up for kidney B. This is probably filled with scar tissue, is my guess. Okay, so again, compensatory hypertrophy. It sounds easy, but keep asking yourself throughout all of these pathologies, would this cause compensatory hypertrophy? Okay. With a UTI, generally it only affects one kidney, not both kidneys. If I'm talking about both kidneys, I will state bilateral. So if I say pyelonephritis, you can assume unilateral. Unless I say bilateral pyelonephritis, then that's two. Okay. All right. So this is the third category here. This gets its own category because it's probably the most complicated one. Okay. This is talking about glomerulonephritis. Glomerulonephritis. Itis, you know it's inflammation. What is inflamed here?
The glomerulus.
Inflammation of the glomerulus. Correct. I'm putting this in parentheses. The glomerulus, not Bowman's capsule. So glomerulonephritis, this is inflammation of the blood vessels, not the thing holding the urine, the Bowman's capsule. Okay. Glomerular disease, we're going to see elevated blood urea nitrogen and elevated creatinine in the blood. So i.e. with glomerulonephritis, we're going to see more urea and more creatinine in the blood. Now think about this. Urea, what should happen to urea? Should be peed out via filtration, reabsorption, or secretion. Urea should be secreted. Creatinine should be
Okay. Filtration.
Creatinine should be filtered. So what I'm getting at is this is supposed to be filtered into the urine. This is supposed to be secreted into the urine. But here they're building up in the blood. So what does that indicate to you?
We're not doing
Impaired filtration,
it.
impaired secretion. I.e., we're probably not making a lot of urine. Okay. So elevated blood urea nitrogen and elevated creatinine in the blood. This is your decreased GFR. This is what we were just talking about. We are not filtering as much. If we have less filtration, we have less reabsorption, we have less secretion. Okay. Now, a little bit of a review. We're talking about inflammation here, correct? What were the two bodily effects of inflammation? Increased capillary permeability, not constriction, but vasodilation. Okay, it's because of these two properties we see glomerulonephritis. Now you remember your glomerulus is like a colander. Okay, if your colander has increased permeability, what do you think is happening to your filtration slits? Getting bigger or smaller? So let me say increased filtration slit size. What were my filtration slits? What was my colander, my glomerulus trying to keep in my blood? Proteins. We're trying to keep our large proteins in the blood. If I have inflammation, what's leaking out now? Proteins in, there's a pee or urine. Okay, so increased capillary permeability means you have increased filtration slit size. You're losing proteins to the urine. Okay. Now vasodilation. You guys remember that ball of yarn it looked like in the 3D? That ball of yarn was surrounded by the Bowman's capsule, right? I want you to imagine you and your best friend jump into the coat closet, and then both of you guys gain 500 pounds in that coat closet. That's your vasodilation. You're getting bigger. Now, if you're stuck in the closet with your best friend, you guys both weigh 500 pounds. What's happening to your ability to breathe? This vasodilation, this is going to decrease perfusion at the glomerulus. So that means it gets so swollen, it kinks itself shut. So what happens to GFR? Decreases. So with glomerulonephritis, two things. A, you stop peeing. But when you do pee, it's going to come out concentrated and what's in the urine? Proteins. Okay. We're going to elaborate on this, but that's kind of like the overview. Okay, so talking about glomerulonephritis, increased glomerular capillary permeability. Means I lose my negative charge barrier and plasma proteins pass into the urine. So what we just talked about. So now, remember how I told you 20 to 25% of your blood's in your kidneys? You're losing 20 to 25% of your blood. Or the proteins. You're losing 20 to 25% of the proteins in your blood to your urine. That's going to cause hypoalbuminemia. What's going on there? Low albumin in the blood. And you guys now know, you don't have albumin, what do you get to look forward to? Just like your liver, just like with your liver dysfunctions. Okay, so with your liver, just your liver not functioning, you're making less albumin. Here, you're peeing it out, there's less in your blood. Okay. So I don't know if this little GIF helps or not. I hope it does. So here's your glomerulus. Notice it's enclosed by your Bowman's capsule. If your glomerulus becomes inflamed, there's limited space in here, and it kinks itself shut. That's why you have a decrease in GFR. Plus your little filtration slits open, and then you lose proteins. Okay. I'll try to give you guys another analogy here. Anybody make drip coffee in the morning? You guys know what I'm talking about?
Yeah.
In the pot, yeah. You have your coffee filter, you put your coffee grounds on there, put the water through the beans, and you got magic bean juice, yes? Now, I want you to imagine that you were super rushed this morning, and you accidentally dump in the entire bag of ground beans. We're talking about 5 pounds in your coffee maker. But you still only put in 2 cups of water. That coffee coming out, it's going to be crack cocaine. Like, it's going to be super concentrated, yes? Now, would you have more or less coffee if you did that than you normally would? You would have less because the coffee grounds absorb all of that water, right? You're in a rush. So what you're going to do is you're going to start pressing on that filter. You're going to start pressing on that filter to squeeze out all the kind of fluid you can. What's going to happen to your filter? It's probably going to break. It's going to tear. What's going to get into your coffee? The coffee grounds. This is the idea here. Your coffee grounds represent proteins. There's pressure built up there. Eventually, the little capillary membrane, the coffee filter, is going to break, leaking your coffee grounds into your urine. Coffee grounds into your coffee, proteins into your urine. Does that kind of help? It's kind of counterintuitive. Because again, you would normally think vasodilation, would you have more or less fluid? Vasodilation, you would normally think if you're vasodilating, you're getting more fluid. With glomerulonephritis, that is not the case. You're getting less fluid because you guys remember it was kind of like kinked. There wasn't. It was a limited space. Okay. So, how does a person get glomerulonephritis? 2 kinds. You have acute glomerulonephritis, which is usually primary. Just kind of lines up that way. Okay, it can be due to a type 2 or type 3 hypersensitivity. Or it can be chronic. Usually most cases of chronic glomerulonephritis are secondary to something else. Secondary to hypertension, diabetes, or lupus. Okay, so again, 2 types of glomerulonephritis, acute or chronic. Acute is usually caused by a type 2 or type 3 hypersensitivity. Chronic is usually caused by something else, and secondary, usually caused by hypertension, diabetes, or lupus. Okay. Now, why do we care about glomerulonephritis? Why do we care about this small specific situation? This is usually the most common cause of end-stage renal failure, i.e., this is the last step before someone's kidneys completely fail. Okay, so this is something to look out for. Last step before renal failure. Okay. All right, so mechanisms of injury up here, these are your acute mechanisms. Okay. Somebody can have streptococcus We just say strep. Think about strep. What do you normally think of? Sore throat. That's usually about it. Okay, but hey, now we know. Remember, we're talking about strep that can lead to things like your splenomegaly. If this infection gets out of hand and it gets stuck in your kidneys, guess what I gotta do to my kidneys to get rid of this infection? Alright, so here's your strep. I tag it with an antibody and it gets stuck in my colander. I need to send neutrophils, phagocytes to start cutting around my colander. They're going to start taking bites out of my glomerulus. That's your type 3 hypersensitivity. Okay. Type 2 hypersensitivity. Anybody remember that one? It's autoimmune, which means, why are my kidneys inflamed with a type 2 hypersensitivity? I'm making antibodies against my glomerulus. I'm attacking my glomerulus. Autoimmune. Okay. Down below, this is chronic. All right, now critical thinking questions. Would you expect to see compensatory hypertrophy with acute glomerulonephritis? The answer is no. Why? It does kind of resolve itself pretty quickly. It's acute. But there's another reason. Why? Why are both kidneys impacted? The infections in the blood. That's the big difference here. Infection in blood. Remember with a UTI, the infection's in the urinary tract because you wiped wrong. Here, the infection's in the blood, strep floating around. Now, if the infection's in my blood, if my phagocytes are in my blood, can I choose which kidney to go to? I'm going to go to both. So would I have compensatory hypertrophy if both kidneys are being damaged? That's the big difference here. E. coli for UTI, that was in the urinary tract. Here is an infection of the blood. Okay. Diabetes, lupus, hypertension. Would you expect compensatory hypertrophy? Think about where would these manifest? Where are my symptoms? Blood or urine? Diabetes is going to affect my blood. Lupus is going to affect my blood. Hypertension affects my blood. So would I have compensatory hypertrophy? No. Okay, again, the problem is in my blood. So looking at these two kidneys here, why do we see a lack of compensatory hypertrophy? Both are diseased, i.e. the infection's in the blood and it's hitting both of them. Make sense? All right, so a couple of kind of lab values that you'll see. You do not need to know this value from me. I'm not going to ask you about it, okay? But nephrotic syndrome, nephrotic and nephritic. There is one letter between those two words. Read carefully. Okay. Nephrotic syndrome, this is protein in the urine, mainly albumin. Nephritic is protein and blood. You only get one. Nephritic syndrome is protein and blood in the urine. So quote unquote, which one's worse? Nephritic is quote unquote more pathological because you're peeing blood and albumin. Both of these, both lead to what blood condition regarding proteins? What will happen to protein levels in the blood with nephrotic or nephritic syndrome?
Grow up.
We'll get there. Anasarca would be fine. I'm just gonna say edema because I'm lazy. Both lead to hypoalbuminemia, which then, i.e., leads to edema. Do you guys see how both of them would lead to low proteins in the blood? Because you're peeing all out. All right, last category. This is the easiest category, renal failure. How many functions does your kidney have? 3. If your kidney stops doing any of those functions, we're in failure. Okay. Acute kidney injury, an AKI, acute, sudden, kidney renal injury, denoting failure. So an acute kidney injury is basically sudden renal failure. Take a moment and pause. What would cause your kidneys to start failing within 3 minutes? Okay. What kind of trauma?
Severe.
Impaired renal blood flow. What would stop all blood to your kidneys within 3-5 minutes? Usually, you guys are all right. I'm just gonna do a little bit easier. Usually due to blood loss. So it could be necrosis because again, I'm bleeding out. It could be a giant blood clot. Seppuku, thankfully, is not really much of a thing anymore. But acute kidney injury, what I'm getting at here is, hey, if you're bleeding out, you've lost all of your blood. Does your kidneys have any more blood to filter, reabsorb, or secrete? That's what I mean by acute kidney injury. Sudden renal failure because you have no blood. Okay. GFR declines, which kind of makes sense. Do you have any blood going to your kidneys? No. Would you see compensatory hypertrophy? No. Why? There's no blood and it affects both and it's short term. Great. All right, chronic renal failure. So this is going to be a slow loss over time. Hypertension, diabetes. Those are the 2 big ones I need you to worry about. Hypertension and diabetes can lead to chronic renal failure, so a slow loss over time. Actually, let's kind of elaborate on this. Proteinuria. Would you have more or less protein in your urine with chronic renal failure? More. Your kidneys are going to fail over time. Should protein be in your urine? Should proteins be in your urine? No. Uremia. Emia means in blood. What is building up in the blood? Urea. Urea in blood. You're building up urea in the blood. We saw that with hepatic encephalopathy. What's that going to do to your blood's pH? Creatinine and urea clearance. Let's say about this. Your kidneys are failing. Would you clear more or less creatinine? Less. Your kidneys are failing. That means you're also failing to clear urea. Fluid and electrolyte, I'm going to say imbalance. Because reabsorption would be messed up. Acid base imbalance. Anemia. That's weird. Why would chronic renal failure lead to anemia?
No, we
Decrease in EPO, which comes from the kidneys. The hypocalcemia, don't worry about that. Didn't talk about it. Remember how I kind of hinted at your vitamin D is finalized in the kidneys. All right, don't overthink this one. Hey, if your kidneys start failing, what else is going to start failing? Done. That is the material for exam 5. Okay? So, kind of what I would mention, what I would say is go through and organize this a little bit here. We talked about upper obstructions, so things like hydroureter, hydronephrosis. Kidney stones can be either one, right? What were the 2 types of infections we talked about? Just now you can do acute and non-infectious. You can do acute and chronic pyelonephritis. That's fine. Glomerulonephritis, there was acute versus chronic. Failure, kidney failure. What was the term for kidney failure? Sudden kidney failure. KI versus chronic. So those are like the categories to kind of get you going, get you started there to help organize your stuff. And what was the thing I kept asking you about with each condition? Would you see comp, hypertrophy? Okay. But yeah, that's what I have for you guys. Welcome back. Shit's about to get real, but got a plan. Okay. Yeah, let me know if you guys have any questions. I'll try to have lecture up sooner rather than later, so you guys can watch it.
Also, I should start this earlier. You might have accidentally muted yourself, you know, I remember seeing it come up on the screen. And then I forgot to tell you you're talking and I ADHD. I don't know, if that's a lecture right now.
Like, she's so mad at you.
You look at it,
Like,
like,
Wait, like